It is my pleasure to introduce the incomparable Dr. Mary Charlton, who's going to talk about the state of cancer in Iowa. Dr. Charlton is the director and principal investigator of the Iowa Cancer Registry. She is a professor of epidemiology at the University of Iowa, and of course, in her most major role, president of the Iowa Cancer Consortium. Help me welcome Dr. Charlton. This is a clicker. Yeah.
Okay. Thank you so much, everybody, for coming today. It's just amazing to see this room fill up more and more every year, and it's great to see you all. Let's see. I didn't see a screen up here, and this is my nightmare scenario where there's no screen, but there is a very slick little screen down here. So let me... Okay, so as joyous as I am to see you all today, it brings me no joy to discuss the numbers that I'm about to present for the state of Iowa. Unfortunately, for the third year in a row here, we are still number 2. We have the second highest cancer incidence in the entire country. That's the age-adjusted incidence, and I'm going to talk about that in a little bit. Our rate is 491.8 per 100,000 people. So all these rates are per 100,000 people. Kentucky is still number 1. They've been number 1 for as long as we've been counting, but they continue to come down and we continue to go up. And if we're not careful in the next few years and do not do everything that we can, we will cross trends with them and we will become the state with the highest cancer burden in the country. Again, we are only one of 2 states with a rising age-adjusted incidence rate. We're the only state for the last 3 rolling time periods that shows up on that list each time. The only other state with a rising cancer incidence rate this time around is Utah, and they are starting from a much lower place. As you can imagine, not so much smoking and drinking over there in Utah, so they are starting at a much lower place. So unfortunately, we have the highest, well, among the highest, with the highest and most rapidly rising cancer rate in the country. So here's how we compare to the rest of the U.S. When we put it on a scale, starting at 0 on the y-axis, you can see we don't look that different, but you can see the distinct trend and that the rest of the country's age-adjusted incidence is going down while ours is going up. If we zoom in a little bit, you can see that trend a little bit better, but I'm just going to spend 30 seconds on a little epidemiology 101 because I want to clarify a couple of things here. When we say age-adjusted, that means we want to compare apples to apples when we compare ourselves to other states. I get a lot of people saying, even looking at this and saying, well, of course our rates are rising. We're older. We have an older population, and that's why. The age-adjusted rates force all populations to look the same. It's a similar distribution. So this is not explained by age. This is our age-specific rates applied to a standard population. But for those of you who are providing cancer care, this is the reality. Our crude rate, our unadjusted rate, looks like this. It's increasing, and here's the rest of the country, which is also increasing. Overall, the United States has an aging population. But you can see the difference between our crude rate, our unadjusted rate, is even wider when we compare it to the rest of the United States. And we're in the top 10 for having the highest unadjusted cancer rate. The only other states in the top 10 for having that high of an unadjusted cancer rate are much older than Iowa. Iowa is not one of the top 10 oldest states, and neither is Kentucky, but we are the 2 states that consistently show up on that list of this is the actual rate, and you can see it is 100 people per 100,000 higher than the rest of the country, and that is what you're feeling in all of your cancer centers, to see more and more cancer patients coming in, and we know that you're dealing with fewer and fewer resources sometimes to take care of them. So that is the reality of what's happening here in Iowa. I get asked a lot by how the rates differ between urban and rural populations. The answer is they don't differ a lot, but what we actually see is the cancer rates are rising more steeply in our urban populations compared to our rural populations, but very similar. I also want to talk about our unfortunate place at some other top 10 and top 20 lists. So when we look by specific cancer sites, We are number one in the highest incidence for oropharyngeal cancer, tied with West Virginia. We are third in non-Hodgkin's lymphoma. We're fourth in leukemia, esophageal cancer, and melanoma. We're eighth in kidney and renal, pelvis, and bladder cancer, 10th in colorectal cancer, 11th in breast and myeloma, 12th in prostate, 13th in lung and uterine cancer, 15th in brain, and 16th in Hodgkin lymphoma. The cancers that are bolded in blue are the ones that are really driving our increasing rates and making us look a lot different from the rest of the country. If you remove the cancers that are in the blue bolded font, our rate actually flattens out and we start to look a lot more like the rest of the country. But all of these cancer sites are driving our high incidence rate. I want to talk a little bit about our incidence rankings by race. We have the second highest incidence rate among our Black population, 7th among our white population, 9th among our Asian Pacific Islander, and so forth. And when I look at state cancer profiles and I restrict to the Black population in the United States, that's where it really sinks in. We, as bad as the rankings were that I showed you before, we do even worse with our Black population. We are first in kidney and leukemia. We're second in colorectal and lung, which are both first if we just restrict to females. We are first among Black males in oropharyngeal cancer. We're third in prostate, liver, bladder, fifth in pancreas, sixth in non-Hodgkin lymphoma, eighth in cervical, and 10th in breast. That is almost every major cancer that we have one of the highest rankings in our Black population in Iowa. The good news, we are pretty average in our mortality rate. Iowa ranks number 24 in the US for age-adjusted mortality. Mississippi is number 1. And we have a decreasing mortality. Like the rest of the US, Iowa's mortality rate is decreasing. And this is usually the point where people start thinking or asking questions, well, maybe it's a good thing that maybe we're just catching more cancers. You know, if we don't have a higher mortality rate, maybe this is okay. Maybe this isn't such a bad story after all. But for those of you who were here last year and heard the very powerful story from Emily from Survivor, she was diagnosed when she was 30 years old with cervical cancer. And she's alive and she's well and she's an oncology data specialist in the Stoddard Cancer Center. And we're so lucky to have her as part of our community. But she can't eat anymore. She gets all of her nutrition through a port. She had to change careers because of that. So yes, there are people who are alive and well, but they are facing very serious consequences of their cancer treatment that they have to face for the rest of their lives. So I sort of reject the story that it's okay that we have this high incidence because our mortality rate's not that bad. We all know cancer survivors who will go through the symptoms, the side effects, and the fear of their cancer coming back for the rest of their lives. And that's why that's not an okay story, and we need to do something about it. And even with an average mortality rate, we still rank highly in some cancers in terms of our death rate, including we're 6th in melanoma, 8th or 10th, depending on how you define childhood cancers, 8th in ovarian, 11th in non-Hodgkin's lymphoma, esophageal and kidney cancer, 14th in uterine, leukemia, myeloma, and prostate, and 18th in lung and brain cancers. Another troubling statistic, though, for our Black population. While we have the 24th highest mortality rate in the country for our entire population, we have the second highest Black cancer mortality rate in the country. And I'm going to break that down a little bit more also. But we do have the 6th highest for Asian Pacific Islanders, 13th for American Indian and Alaska Natives. So we have subpopulations here in Iowa who we're not helping prevent cancer. We're not helping detect their cancer early, and they're not getting the same and equivalent treatment as the rest of our population and not having as good as outcomes. And this is another way to look at it. This is showing the blue dots in this graph represent the mortality rate among Black patients, and the gray is among white patients. And you can see that Iowa has the third, behind DC, the third biggest spread, that third biggest gap between the mortality rates between our Black and white populations. And again, the second highest cancer mortality rate among our Black population. In some maps I'm going to show you later, it's clear that we have a lot of disparities. Waterloo, for example, continues to be one of the most segregated cities in America. And just looking at their cancer risk, the difference between the east side of Waterloo, the west side of Waterloo, and Cedar Falls is stark. And they are all in the same geographic area. It tells us that we need to do better. And so what all this means to have a very high and rapidly increasing incidence rate and an average mortality rate means that we are accruing cancer survivors in our state at a very rapid clip. You can see Iowa in the yellow line. This is sort of assuming, this is making a lot of assumptions, assumes nobody ever comes and goes from Iowa, so that's not exactly correct assumption, but we have data going back to 1973 at our cancer registry, and you can see over time that our number of cancer survivors just keeps increasing, and we are at more than 1 in 20 people in Iowa living with cancer. Connecticut is one of the SEER registries that also has data back to 1973 that it has a higher rate or prevalence rate than we do, rate of survivors, but they're a much older population, so that is why. And they also have a longer survival time for their patients. They have better outcomes there. So this is something we all need to be aware of, is that every year on year, we're gaining thousands of cancer survivors in our state that all have unique and special needs, and that will be a focus of the Cancer in Iowa report for 2025. My message today for all of you is there does not appear to be one thing causing all the cancer in Iowa. I get questions all the time, as you can imagine, is it this? Is it that? Is it this thing? My answer is yes, it is all the things. But we look at our data at the registry and we can see that it is not just one thing. This was a great infographic, I thought, coming out of the American Association for Cancer Research, looking at attributable risk for selected risk factors. We can see that cigarette smoking continues to be one of the biggest risk factors for cancer, followed by excess body weight, alcohol consumption, ultraviolet radiation exposure, poor diet, pathogenic infections like HPV, and physical inactivity. So how do I know it's not just one thing causing all the cancer in Iowa? Well, one way is looking at maps of where we see different types of cancer. We're using cancer reporting zones here, which is a project we worked with the NCI SEER program and their contractor Westat. And that allowed us to combine or collapse counties together that have very low rates of, or not low rates of cancer, but small populations, so that we could get a very stable risk estimate. It also allowed us to break up counties that are more highly populated, so that we can look within communities better. And you can see Waterloo, case in point, in the purple being higher incidence and the light yellow being lower incidence. We broke Waterloo apart following the river, following the redlining, following the historical significance of how people were divided in Waterloo. And you can see on one side of the river, they have one of the highest cancer incidence rates in the state. And on the other side, they have among the lowest. And that is in one geographic area. When we look at the different cancer sites, we can see with breast, we see the highest incidence in the cities. With colorectal cancer, it's almost the exact opposite. It's the highest rates in a lot of the rural areas. With prostate cancer, the highest incidence rates are in the west. With kidney cancer, you see a little bit in the west and kind of scattered around. Then we have the cancers that are more, that the incidence rates are higher in the south, things like lung, pancreatic, bladder. Then we have the cancers where they're higher in the north, like melanoma, non-Hodgkin's lymphoma, and leukemia. All very different patterns. These cancers have different risk factors and they affect different populations. And so this is one way that we know it can't just be one thing causing all the cancer in Iowa. In terms of our modifiable risk factors, how do we rank? Well, not very well. We're third in binge drinking. Since the Cancer in Iowa report coming out last year, we were fourth. Now we've moved up to third. And with 22% of our population, or more than 1 in 5 people, reporting binge drinking on the behavioral risk factor surveillance system. And that is across all population demographics. And where Iowa really stands out in that statistic is almost the wealthier you get, the more educated you get, the further we get away from the drinking patterns of the rest of the country, the worse we get. So this is not a risk factor that's limited to people who don't know better. I always joke that at the cancer conferences I go to, you don't see very many people smoking out on the breaks, but you see everybody at the bar after the cancer conference, myself included. So that is something that is in our culture. It is something it is something sort of ingrained here. I can tell you that one change I made myself after writing the Cancer in Iowa report with my team, which, by the way, I received the nickname Dr. Buzzkill after doing that, which I now have to live with. But for myself, I thought, what are the benefits of drinking alcohol to me? Well, socially, there is benefits to doing that. So I have, for my own self, I have tried to restrict drinking alcohol alone, and my kids don't count, and neither does my dog. So that is one small change that I have made. I certainly know that it's not realistic to expect the entire state of Iowa to stop drinking. But I think it is realistic to ask the entire state of Iowa to stop binge drinking. And I think there are a lot of things that we can do to get out of that third ranking spot. We were 21st in smoking, with 15% of our population still smoking, and a paper came out that shows that Iowa has made about the least progress of any of the 50 states in decreasing our lung cancer incidence rate. We were 11th in no physical activity, with a quarter of our people reporting absolutely no physical activity on any regular basis, and we are 12th in obesity at 37.4%. And just wanted to compare, I'm always comparing us to Kentucky, because I'd like us to stay out of that number one spot. So you can see the people in Kentucky, even with their very high cancer rates, they must be slowly sipping their bourbon down there while we are rapidly knocking back our Templeton Rye and Busch Light here in Iowa. We don't smoke all that much less than Kentucky, and Kentucky's making progress all the time. They are investing a lot of resources and efforts into reducing the smoking rate, which will in turn reduce their cancer incidence rate and their mortality rate. We are similar to Kentucky in our obesity rate and similar in our physical inactivity rate. The good news is our cancer screening rates continue to be relatively high. A lot of people ask, well, is our cancer incidence rate increasing because we're screening more? Unfortunately, no. We do have good screening rates, but they are not increasing proportionally with the rate of new cancers. You can see that we have a lot of progress we can make in lung cancer screening, and that's a project that several of us are working on at the University of Iowa to increase lung cancer screening. That's a huge opportunity to make a big impact and catch that cancer early, which is typically a very deadly cancer unless you can catch it at an early stage. So again, cancer is multifactorial, meaning it is caused by multiple risk factors working together to alter the way cells function. There is no one cause for cancer. It is the complex interplay of different genetic, behavioral, environmental, and structural factors. Everybody knows somebody who smoked their entire life and never got lung cancer, and everybody knows somebody who never smoked their whole life and got lung cancer. It's never just one thing. To reduce the risk of cancer, though, it is important to reduce our exposure to modifiable risk factors. And again, I use the analogy that I always use, Trivial Pursuit, which, back in the day, you wanted to fill in the different pieces of the pie to win the game. But unfortunately, it's a good analogy to cancer in that you don't want to fill in those pieces of the pie. And some of those pieces get filled in for you just by virtue of your genetics, your sex, your race, the things that you cannot modify. But we do need to not put the pieces in the pie for all of the other things that we can control. And it's not fair to say that each of us individually can always do those things on our own. We need a public health system, and we need programs that make it easier to do the healthy things and harder to do the unhealthy things and turn that around. Because right now, it's almost always easier to do the unhealthy things. And I also wanted to let you all know about an exciting project that we have coming up that was funded by a supplemental grant from the National Cancer Institute. We are creating community cancer profiles at the Iowa Cancer Registry for all 99 counties. These county profiles will include rankings and trends in incidence and mortality by cancer type, maps illustrating how they compare to other areas in Iowa, risk factors and prevention and screening behaviors for the county, and recommendations and resources on cancer prevention and control priorities for their community. We plan to deliver a lot of these reports virtually, some in person, to groups of local public health professionals, policymakers, healthcare providers, advocates, and any interested residents. We want to use our data to the fullest extent possible to educate people about what's happening in their own community and help them figure out what they can do right now to help turn around this trend of our rising cancer incidence. And we also want to include time to listen to community concerns and ideas. It's got to be at the local level. It's got to be at the state level. It's got to be at every level what we're doing to work on this, to decrease our cancer burden. And a lot of it, though, needs to start locally, and we need to listen, and we need to work together, and we need to figure this out. So we look forward to coming to your town, either in person or virtually, and we'll be reaching out to a lot of you to help set up those meetings, and we'll be making the reports available online. So thank you to everybody for all the amazing work. It is going to take all of us in the room and then some for me to come back one of these years to tell you great news. We are number 3, 4, 10, 25, and our cancer rates are declining. I can't wait for that day, and I'm so grateful to have all of you as partners in working on that. So thank you for being here today.